Hi, Paul. I think you're on. Hi, welcome everybody. We're now live. We're going to give just a couple minutes to make sure everyone has logged in and is registered okay. Just a couple minutes to make sure. We're also going to put in the chat the link to our course website, which has all of the materials for today. Then we're going to get started in about 1 minute. If you haven't checked out the course materials, please click on the link in the chat. And if you click on session 1, you can see all of the readings for today, including the case study. Okay, we're going to get started. Welcome to our executive leadership course entitled An Equity Approach to Pandemic Preparedness and Response, Emerging Insights from COVID-19 Global Response Leaders. This is a course offered jointly by Partners in Health and the University of Global Health Equity. I'm Amy DiMatteo, Senior Manager for Project Operations for the Learning Collaborative at Partners in Health, and I'm going to give you a few course details as we start. Next slide, please. This course has 4 sessions in total. Each session starts at 10 a.m. Eastern or 1600 4 p.m. Central African Time. The sessions all last 1.5 hours with an optional question and answer time after that. Next slide, please. To receive certification for the course, please join us for each of the 4 webinar sessions. If you cannot join live, you can watch the recorded video, which will be posted at our website shortly after the webinar session ends. After watching each webinar, please complete each session's assessment survey. The survey gives us feedback on the session and it checks your understanding of the material in the course. The website link has been put in the chat function to the right of your screen. Please feel free to click that website link and scroll down to the box labeled Session 1. Click Learn More, and there you will find all the materials for this session, including today's case study that will be presented entitled The 21st Century Pandemic, COVID-19 and Health Equity. You will also find additional readings and a link to the assessment survey that you can complete after the session. During today's webinar, please submit any questions you have for us in the Q&A section on Zoom. You will not be able to submit anything in the chat section to us. So again, please place any technical questions or any questions you would like to ask the panelists related to the course material in the Q&A function. And we'll have staff who will be monitoring the Q&A function throughout the webinar session. Next slide. Thank you, and I will now turn it over to our course director, one of our course directors, Dr. Anatol Manzi.
Thank you, Amy. My name is Anatol Manzi, as Amy just mentioned, and I am the Deputy Chief Medical Officer at Partners in Health and the co-director of this course. Welcome everyone to Partners in Health and the University of Global Health Equity. The agenda is here. So soon we're going to have a keynote address from our CEO, Dr. Sheila Davis. And then we will have a case study presentation followed by a panel discussion. Then we have enough time for questions and answers. Next. I always felt that we are surrounded, virtually surrounded, but this time I feel it. We have over 2,000 participants from 80 countries. This is amazing. So I want to turn this to my colleague, Dr. Phaedra Henley, to give us a preview of the course, and then we're going to kick it off. Thank you.
Thanks so much, Manzi, and hi, everyone. Welcome to the course. As you mentioned, my name is Phaedra Henley, and I'm the director of our Center for One Health at the University of Global Health Equity, and I'm super excited to be co-directing this course with Manzi. So this is a timely course as we've seen COVID-19 is still ravaging the world and has shot a massive spotlight on the deep and deadly cracks that exist in our societies. From the disproportionate infections and death in the impoverished and marginalized communities, to the failure of leadership in many countries to contain the pandemic, and to once again recognizing that the emergence of infectious disease outbreaks directly relate to the destruction of our environment. Building on the implementation and academic experiences of both Partners in Health and the University of Global Health Equity, we are presenting a critical approach, one that is founded in equity to pandemic preparedness and response, lessons that can apply to many global health crises, including future epidemics. At the end of these 4 sessions, you will be able to evaluate and improve the practices, tools, and resources needed to effectively combat COVID-19 and other epidemics. You will recognize the critical roles of leadership, policymakers, implementers, and community members themselves in an effective response. Overall, as we guide you through the 4 case studies and learn from our global response leaders, you will understand that with health equity as a central principle, there is hope to overcome and recover from COVID-19 and to be better prepared for future infectious disease outbreaks and global health crises. So really excited to have you all here today, and I'll turn it back to Manzi.
Thanks, Phaedra. Again, I just mentioned that we are surrounded, virtually surrounded. We have people from the United States, Rwanda, from Nigeria to Canada, Zimbabwe to Liberia, Kenya, Uganda, Great Britain, and Sierra Leone, and many more. So without taking too much time, we are here with a leader, a friend, and CEO of Partners in Health, Dr. Sheila Davis, for the opening remarks.
Thank you, Manzi. I want to add my thanks to everyone for joining. And if there's ever a time when we need to count on our greater global community, I think it's at times like these. And the fact that there's been so much interest with not a lot of timing and the short preparation time, the fact that this course has come together, I think is a testament to the fact that we know we are a global community, and our times for us to be able to learning from each other and contributing to each other and how we can fight a pandemic such as this is as even more critical than in non-crisis times. First slide. So Partners in Health, we're a nonprofit social justice organization. Our goal is really to make health a human right, and we work in the most vulnerable communities in the world. Many of our staff, we have over 19,000 staff, we work in 11 countries, and our staff are the people who are the experts who have contributed to this entire course and to our global health learning as a whole. We definitely believe that partnering with the public sector, so working with ministries of health, working with other NGOs, working with a variety of other partners is the key way that we're going to be able to provide health as a human right in places where that has not been able to happen. This epidemic has really illuminated that this virus has cut across and really shown and unevenly impacted across lines of gender, of race, of class, of geography. And it's only through our shared learning and commitment to guaranteeing health as a human right, regardless of geography, that we're going to be able to care for our most vulnerable in the world. Next slide. So these are the countries that Partners in Health works, and our goal really is that we approach things via a global equity lens. So we're learning from our colleagues in Rwanda, which you'll hear about during this course, and we've brought those learnings to Massachusetts. In Massachusetts, we've brought those learnings to many other states within the US and municipalities. And none of us have the answers to this, but I think in what we've learned in global health is that there are no experts, and we continue to learn from each other with basic epidemiological tools like contact tracing, something that's been around for years and that we did during Ebola, during cholera in Haiti, for MDR TB in Peru. And these lessons learned are really critical for a pandemic like COVID-19. And we've been able to, through the network of Partners in Health, meet every day as a group virtually and share and support each other and bring the best practices. And now we're very excited to be able to share these with a large audience. Next slide, please. So we believe in pragmatic solidarity, and what I think is important about this is the pragmatic piece of this. So I think we all can have many different ideas of how best we can support and treat something like COVID, but it's only through actually the act of being and walking side by side with people that we're able to, I think, effectively address these global inequities. So our accompaniment model is something that we're doing during COVID-19, as well as during our everyday knowledge of what we're doing. And we're accompagnators just as we're all being accompanied every day. And certainly having the honor of working with such a large group of people around the world, I definitely feel accompanied by the many leaders and staff around the world who are combating COVID on a daily basis. Next slide. So the why and how. So if we're an organization that we believe very firmly that social justice is an important component of how we should all be living our day, how we address it is that we're a clinical organization. We don't just do clinical work, we also do operations, we have drivers, we have cooks, we have housekeepers. This entire machine is what enables us to fight injustice by bringing modern medical advances to places that typically have not had access to this. So an important piece of our being an organization that is focused on social justice is that we're utilizing our pragmatic solidarity in the form of being a clinical organization and partnering with clinicians and others and Ministry of Health colleagues around the world. Next slide. So Expert Mercy, Dr. Paul Farmer, who you'll hear about later today, talks a lot about Expert Mercy. And this is something that has struck me for the first time, a lot since the first time I heard this from him. And I think this is important because it really shows that there's not one size fits all, or there's not one silver bullet that is going to stop a virus like COVID-19. It depends on what's needed at that time in this place. In the US, we've certainly found that there's a lot of cracks in our public health system. We don't have as strong a public health system as we should have, not because there are not public health experts here, but it has been defunded for decades. In other countries where we're working, we don't have ICUs, we don't have ventilators. So we really are seeing that there's not one size fits all, and we need to be fighting and continue to improve the access to care for ICUs, not just during times of pandemic, but terms in all times, as definitely people all deserve this type of care. So when Paul talks about Extra Mercy, he says, when you're dehydrated from fever and you can't keep down fluids, it looks like IV fluids. When you're quarantined with a mild case of COVID-19, such mercy may be dispensed at home. But when you're critically ill, Expert Mercy looks like expert nursing care. When you're coughing and short of breath, Expert Mercy is an oxygen mask or a mechanical ventilator. I think it's important that we keep this in mind as we're looking through this this course over the next few days, and remember that it's critical that as we're battling one piece of a gap that's been exposed, that we're still also looking beyond to other places that are battling and have a different gap. So as we're fighting for an adequate public health system in the US, we need to continue to fight for the ICUs and critical care in places like Sierra Leone and Liberia. Next slide. So the University of Global Health Equity, this is such an exciting place. The university in Rwanda, which you'll hear more about. And the entire goal of this university is to create the next generation of global health leaders with an equity lens. So it's an amazing opportunity for people to be able to learn from each other, for this to be a convener such as for global health communities such as we are today, and also pushing ourselves to look beyond typical global health or clinical topics and look at gender equity, look at One Health. It's only through places like the University of Global Health Equity are we going to be able to really transform the future so that pandemics are not able to devastate as they currently are today. Next slide. So the university, as I said, is a place that has been bustling and has medical school master's programs, a Center for Gender Equity, and I think is a place where I invite all of you to learn about. And this is all of our university. This is a place where we can all come to learn from each other. This is just the beginning of the university addressing something like COVID-19, and look forward to all of us learning from each other and contributing to making the world a better place for all of us. Next slide. So our global health experts we'll hear about today are Dr. Paul Farmer, who we know has been a leader in global health for decades, as well as Dr. Agnès Benguahou, who is the Vice Chancellor of the university and someone I've been very happy to get to know better this past year, and is somebody who I think is continuing to push us and drive us to addressing equity throughout the entire campus, throughout the entire program. Dr. Abebe Bekele, who is the Dean and the Vice Chancellor of Academic and Research Affairs, is someone who also has been bringing his expertise as a physician and a surgeon and driving all the clinical programs and our academic programs forward. And last but not least, my dear friend and mentor, Dr. Joy Mukherjee, who's the Chief Medical Officer of Partners in Health, who is going to kick us off today and guide us through today's cases and questions and answers. Thank you.
Thank you, Sheila. My welcome and my thanks to our team who put this together at the behest and the desire of so many of you around the world for, what are we at Partners in Health, at UGHE, what are we thinking about this pandemic? And so we'll be talking about that specifically related to health equity. I think many of you have probably been on webinars, have taken courses, and what we feel is our added value here is really the focus on the vulnerable, not only today, but always, and not only in the delivery of expert mercy, as Sheila talked about, but the analysis of how pandemics travel along the fault lines of our global community and individual societies. Next slide. So our learning objectives are really to look at this global inequity and what were the actually early warning indicators, not only of the pandemic, but of the inequity that we would face. To understand this legacy of inequity within and among countries, so between countries, within countries, we certainly see this in the US, and we'll give some of that perspective as well. To discuss the role of leadership for effective preparedness and response, and how that is also linked to equity and justice. To understand the relationship of clinical care, social support, and the public health response as a continuum and important interconnected pieces of our response. And to understand these basic principles for developing and sustaining an equitable and effective response to pandemics. Next slide. So some of the core concepts that we'll be talking about throughout this course are social medicine, the social determinants of health, or as we often call them, the social forces. They are not determinant by geography. They're caused by history, by politics, by choices that are made. And then, what this pandemic really looks like, and what does that really mean to us? Next slide. So I think the evolution of the pandemic is well known, and you will all be welcome to come back and look at these slides. So I don't want to spend too much time on this, but from the first known case in December of 19 to today, what we see is not only a global and massive pandemic, but one that is very unequal. Next slide. So here are some lessons, some of the interesting legacies and how we think about it. We hear a lot about the Spanish flu, and there were 50 million people who died. In 1918, there were far less ability to do advanced medical care, but yet there is still a lot of evidence that the flu disproportionately affected the poor because of food insecurity, housing insecurity. Then we look at Ebola, whether it was this most recent outbreak in Congo or the West African Ebola crisis in 2014-15, which we'll be hearing a bit more about. And again, in war-torn areas, in areas that have less health infrastructure, this disease is able to rapidly spread. So Ebola is the same pathogen, whether it's in Dallas, the United States, or in Liberia, and yet we see very, very different outcomes, very different risks. And then our experience collectively across Partners in Health and also in Rwanda of what to do in a pandemic like HIV. We were among those, with many of you who are on the phone today and around the world, who fought for treatment as part of the epidemic response. What a lot of public health told us is prevention is enough. And we said, no, prevention and treatment and social support. Next slide. So we believe that the cost of having poor health systems is what sets us up for pandemic spread and these disproportionate effects. And, so as you see, we have, a slide looking at sub-Saharan Africa and a slide looking at the United States, because we know that whether a country has wealth or not, it may or may not have the right political choices to put the cost in to have comprehensive pro-equity and pro-justice health systems. And we are going to see that play out in COVID. We are seeing that everywhere in the world, and certainly the United States is leading the way in really showing what poor choices look like in a pandemic. Next slide. So these are the three comprehensive elements that we will be talking about through the course. The need for strong public health systems, that is clear. Testing, contact tracing, good communications, good policies, letting the population know what it is they're up against. These are critical. This is a cornerstone of public health. But what we have learned over many decades is that that alone is insufficient. You have to be able to treat people. And in this terrible pandemic, people need oxygen, they need ventilators. And the provision of high quality care should not be only for those who are born in a wealthy country or who are born white in a wealthy country. And so this is really the other important pillar. And none of these, neither the prevention aspect or the treatment aspect will work sufficiently well if you do not have economic and social support to the vulnerable. Because we know that for people to access information on how to protect themselves, to be able to go to a hospital, depends on their means of survival. Next slide. So we will be talking a lot throughout the course about the Partners in Health model and how that's reflected and taught in the University of Global Health Equity. We'll also hear from the folks running the response in Rwanda, a country that is very much driven by health equity. But we talk about really 5 different elements, and this is for health systems writ large and applies to the pandemic. Having adequate staff, well-trained, well-compensated, having the supplies. And, you know, we've heard so much about PPE as one of the key supplies, but there are many others. Having dignified, clean, adequate space, having the systems where one can follow up, where there's good referral mechanisms. And then, as I mentioned, the social support, which might be food, it might be housing, it might be cash. These are the 5 elements that we have really determined are what differentiates a strong health system and a strong and just society from a weaker one. Next slide. As you can see, in terms of pandemic preparedness, we believe that the statistics really show a level of readiness. And in fact, right now, while we do expect things to get worse in Africa, there are many, many lessons learned on the continent about how to link public health, health care delivery, and social support. And we are really excited to learn from our colleagues in Rwanda and across the continent on how it is that they seem to be more ready. And readiness is not something we do by a task force. Readiness is not something you do with a document. Readiness is a systematic and systemic approach. Next slide. So we will be talking about these strategies of serving the vulnerable. And there are a couple of really important principles, these 6 principles that we will be seeing throughout. One is that lockdown, social distancing, many of the standard public health messages will fail if people do not have the agency or the material means to carry out these messages. If you have no food, you cannot lock down, right? Food security, housing, providing transportation fees and cash are health interventions because they are crucial to mitigate the harm being done by the social impacts of COVID and the social inequalities that already exist. We believe that community members play a central role in responding to crises, both in finding cases and supporting their neighbors, and in passing messages. That the public provision of healthcare prior to, during, and after the epidemic constitute the most durable form of pandemic preparedness. Again, it is not about a task force or a document. It is really about what is the system of care before, how does that handle the epidemic during, and what can we build stronger in the aftermath. We believe that contact tracing and investigation helps to stop the spread of epidemics, but it's best done by community members and in the context of available high quality care and social support. Again, a triad. And then lastly, that leadership in a pandemic should always be accountable for the outcomes of the most vulnerable. And when we see countries that have successfully responded, they're ones that are looking at the most vulnerable. Next slide. So I want to thank you all very much, and we will use the rest of our time here to have a discussion with Dr. Agnes Benaguajo, Dr. Paul Farmer, and Dr. Abebe Bekele. And I know there will be a lot of questions, and we would encourage you to use the question and answer function. But I want to start by putting my first question to Dr. Agnes Benaguajo, my sister and good friend, to talk to us about what it was like to be the Minister of Health when Ebola was ravaging West Africa, and how one would approach it from the country of Rwanda that had put a lot of investments in health systems. Dr. Agnes. You're on mute, Dr. Agnes. Dr. Agnes, you're on mute. There we go.
Okay, sorry for that. Hello, everybody, whatever place you are in the world, is going to be a great discussion. And what I'm going to share with you is where Rwanda was at the time of the 2014-2015 Ebola outbreak that was in several African countries, but went up to Spain and to the US. I want to recall that the Rwanda health system was broken during the 1994 genocide against the Tutsi, where 1 million Rwanda were killed. The country has since prospered, and as the result of a decisive, adaptable, compassionate, and evidence-based leadership. I say that because it's very important in preparation and response to outbreak. This has driven economic and human development based on equity. All the policies are based on equity and leave no one out. And the success of fighting Ebola in 2014, 2015, and the success of COVID-19 preparedness and response today are the result of existing program and financing initiative built by the Ministry of Health and the government, but embedded in the principle of equity, leaving no one out. First, equity, geographic equity is guaranteed by building, I contribute to build the health system on the decentralization structure of the country, making sure that each village has the same number of community health workers. Each sector, we have 416, have a health center, and each district, a district hospital. But what is important for the preparedness, each of those structures, the health workers and the community health workers were trained on the risk of being contaminated, or what the disease is, how to protect themselves, how to contribute to protect the communities, and giving also what it takes to protect themselves so that they are not going on front line to die for us where we are safe in our home. And we have also in each hospital for the Ebola, they had to create, and it has been really improved since then, they had to have an isolation room, a transition room, they have to have the infrastructure to protect themselves, protect the patient, and protect the population. Because we doesn't have to forget that all the persons suspected to be infected are not infected. So we should not be the causes of them being infected by not creating the right infrastructure to welcome them. So systematic testing in case of suspicion, systematic contact tracing and testing all the contacts. It's still done now. What has been done has been improved. And for this, we had, in 2014, we create an army of disease detectives, people that in each district were ready and on call of a person suspected to be infected, go and immediately start the contact tracing and direct them for the testing. The reporting was centralized and shared with all districts so that improvement can be done as we go. And we make our best to keep functioning primary care, where the people receive maternal and child health care and ordinary care, especially at community level, that reimbursed by the Mutuelle de Santé, where 90% of Rwandan are affiliated. So outbreak after outbreak, Rwanda have created a system that can be functional in less than 24 hours for the next. And we improve. This time we improve it again. Also, leaving no one out and taking care about the vulnerable. Equity agenda mean if you ask people to stay home and to be quarantined to protect the nation, you need to make sure that when they are poor, they receive food on their plate every day. If not, there is no reason them to die starving for the rest of the nation to be healthy. Also to make sure that all those tests that are really unaffordable, the quarantine for some of them, and the treatment are free. If not, they will not come. And if they don't come, the disease will spread. This is what I can share with you, my sister.
Thank you so much, Dr. Agnes. And I know there will be a lot of questions. I want to turn it over to Paul, Dr. Paul Farmer, the Kolikatronis University professor and our dear friend for many years. No, Paul, I think there's already a question about Haiti, a question about stigma. But what I'm hoping you can share with us is really some of the theories that help you to think about implementation of a response as a physician and an anthropologist.
You know, thank you very much, Joya, and thank you, all of you, Monzi and others who organized this course. You know, that example of the questions coming in about stigma is pertinent to a discussion of what social medicine is or what is intended by that rubric here. And instead of going into any kind of overview of that tradition, which is, you know, a couple centuries old, I'll just apply it to some of the things that Agnes was talking about. But the basics are that it doesn't mean that we're just going to study something that isn't readily studied inside a hospital, like stigma, which requires careful community-based and ethnographic work. It means looking around. Okay, so anthropology, which I studied, is one of those disciplines that is supposed to be socializing, to allow you to look around at what's in front of you. Some of it hidden, some of it evoked by just conversations with those who one is living with and working with. It also means looking back. So a robust social history of a problem. In this case, if you were to take a look at, so what have epidemic responses been like in, let's say, Central Africa over the last 100 years, or in West Africa where the Ebola epidemic happened? We actually have some answers to those questions because of historians, anthropologists, sociologists, economists, or at least political economists, looking at these problems. So my argument here is that social medicine is alive to power, to nuance, to change, particularly, and to social disparities. But by itself, that approach doesn't bring you anything. After all, there have been plenty of dictatorial regimes and bad ones that have been quite aware of how power works in the world. It's what the deliverable is that matters. So the deliverable for Rwanda in 2014 was to call up a social mobilization, quite explicitly, and to address questions of stigma in the training programs and over the years, and to focus on a social mobilization that would serve those who had not been served well previously. Now, there will come a time when Rwanda can't say, we're serving those who were not served well previously, because they're doing a good job reaching out into rural areas, to the poor, and a lot of the work that was done, and not just the poor, people living in rural areas who are shut away from ready access to what is seen in all these capital cities across the world. So that was already a social medicine structure, if you will, that informed and not only this response, the 2014 Ebola response, but several others that we've been lucky enough to witness, and which Joya has brought up in her talk. They all involve accompaniment, engagement, really just listening to people and hearing what they say, because it takes absolutely no time to find out that people are afraid of food insecurity and water insecurity and a host of other very ostensibly pedestrian problems, but of course, as Joya put it so clearly, they are exactly what will make people unable to work as part of this social mobilization. Before I leave and turn this back to you, I just want to say that not only were we impressed, even from afar, because many of us were in West Africa responding to Ebola, not only were we impressed by the response, but how well it could be, as Dr. Agnes said, invoked on short order to respond to others, because there have been more than one epidemic in the Eastern Congo in recent years. This is a long-standing pattern of Agnes's and others. I remember back in 2003, for the first AIDS plan, the National AIDS Plan, actually had an entire accompaniment section, an entire section on food security, social supports. And yes, there was plenty about stigma, but people did not also attended to the material needs of those who would be served in this case by the National AIDS Program. I hope we get a chance to go back to stigma, Joya.
Yes.
You know, if you look online at AIDS and stigma, you find, like, you know, just scholarly papers or things that can be assayed in a big database. You can find 5,000 articles and studies and commentaries about AIDS and stigma, but according to Jean Richardson, fewer than 200 about AIDS and racism. So when do large-scale social forces like colonialism, racism get erased by an undue focus on the cultural and cognitive responses of people to lethal pathogens? That's one of the questions I hope we return to.
Yeah, that's great. Thank you, Paul. And there was a question, another question about stigma from Tanzania, and also the idea of that's really needing behavior change. And I think what we're seeing around the world is, you know, there is always suspicion with a new disease. There's always fear. These are normal human things. These are not culturally baked into a Tanzanian context or a, you know, Michigan context in the United States. But what we have seen over and over is what changes stigma is the availability of treatment and leadership, very clear communication about what can be done from a social standpoint, from a health standpoint. And so this is a good opportunity to go to my friend, Dean Bekele. Dean Bekele is a surgeon, and he's also an educator. And Dr. Bekele, I hope you will talk about sort of what the equity lens you're using to teach at UGHE, how that's part of the framing, and also how the university can support the community, because often we are in our intellectual bubble. We talk about in the United States the town and gown, but what you're trying to do is really have the understanding be a shared understanding. So will you share some of that and how that relates to teaching equity in a pandemic?
Yes, thank you, Joya. Good morning, good afternoon, everyone. As we have seen over the past 5-6 months, COVID has been a serious source of injustice globally. The previous panelists have discussed food shortages, food insecurity, to the extent of national stability of some of the African countries. Academics and research is no different. COVID has seriously disrupted the way we teach, we do research across the globe. Unfortunately, almost all the medical schools in the region are shut down because of social distancing. Campuses are shut down. The global advice is to shift to e-learning. Unfortunately, e-learning needs investment and predetermined investment, to be very precise. And very few medical schools at the moment are teaching their students. Residency programs have been completely shut down, particularly those that need practice, like surgery. Exams, teaching, sessions are either postponed or cancelled. So the academic world has been severely ravaged by this virus. When we talk about equity and community for a university like UGHE, our community starts from our students and faculty. Their safety is our concern. So what we have done is that through a very strong integrated leadership, we set up an emergency preparedness unit where all the things we do to prevent COVID in the region is integrated. Our university is based in a deep rural community in Rwanda. Anything we do in the campus reflects on them. So we need to protect not only our university, but the community too. So our students are now in the campus, well protected. Our campus is off limits, no one can go in and go out. However, the best thing is that academics is still going on. We were lucky enough to invest significantly on e-learning, so it was not difficult for us to change our didactic teaching, our face-to-face teaching to e-learning. We're one of the very few medical schools in the region that are still teaching. So this is one thing that COVID has brought in. And I'm afraid the world will never be the same again as far as academics is concerned, unless our students, our faculty, our staff are well aware that their safety, the students' safety, the safety of the community around us depend on us, our intellectuals, our faculty, unless they come forward and teach the community, educate the community, educate for public good, be engaged in research and have the papers out there to support policymakers in leading the fight against pandemics like COVID, will probably lose the war. I think COVID-19 is a warning sign. I think has shown us that we are not yet prepared in all aspects, academics and research being the same. We are not prepared to handle such a pandemic. So it's now a learning curve for all of us to be prepared on time, anticipate such disasters, and adapt as we move along.
Yeah, and can you add, Dr. Abebe, something about how different equity principles are baked in, before COVID, into the student selection, into how you're teaching, and into how you engage the community?
Yes, thank you, Joya. As a principle, one of the definitions of equity at UGH is equal access, equal opportunity. So in our medical school, we make sure we recruit trainees from the community that is underserved, that do not hear about announcements, that do not hear about opportunities. So we try to reach out all high schools in Rwanda and make sure opportunities are announced. What we say is anyone with the brains, the heart, the brain, and the hands to join health education should be given the opportunity to do so, irrespective of who they are, where they are from, or who they know. That is the selection principle we follow. Our recruitment is open globally. We recruit globally to our MGHD program. Our Masters in Global Health Delivery program is a very famous program with a recruitment rate of less than 4%, and it's a highly sought after program. The second thing is that we have set up what we call our social community health and social medicine department, mainly to work with the Butaro community and our surrounding. We support the high schools, we support elementary schools. We work very closely with the Butaro District Hospital and its affiliate health centers, and we engage the community in all our UGH business. Whatever faculty and students eat in the campus is sourced from the region, from the Butaro district. We hire as much as we can from the Butaro community. And we recently launched a program where our faculty, our PhD and master's level faculty, will donate 1 day per week to work with faculty and teachers in the different high schools, so that science and STEM education can be strengthened in these communities. This is just a few of what we do to support the community.
That's so great, Dr. Abebe. Yes, Dr. Agnes.
I want also to say that because the cost of good education is high, whatever place you are in the world, we make our responsibility to make it free for the students who do medical education, and in compensation to give back to the world, they commit to work for 6 years minimum for people in need, keeping their salary, but giving back as a social justice act. And we call that Umusanzu.
That's great. That's great. And again, it's different than, let's say, a bond, right? When we talk about bonded labor, that's not what we want. We want people to understand, and we've seen this in Haiti, and elsewhere, that if people start to work, and in the US as well, like if people really start to get used to working in this way and with a community and proximate to suffering, they often get the bug and they want to stay and to do that. Paul, you know, there's a great question that highlights something you wanted to go back to from our own Tom Snyder in Liberia, who runs the social support program for the Annex, as you know. And he's talking about stigma, but also knows well the perspective of social medicine. So if you want to kind of address those questions of how social medicine and social support can help deal with stigma, and what do you think is the stigma that it's coming from that?
Thanks so much, and thank you, Tom. You know, first, I hasten to add, obviously, that stigma is a serious problem. A number of us have done, including Agnes, have done a lot of research on the way that stigma gets in the body. For example, her doctoral research examined this with children and adolescents with HIV. So that's not to be trivialized. The real question, as you and Tom put it, is where does it come from and how can it be addressed? And one of the things that we've been clamoring for during the American COVID epidemic is to say, don't blame disparate health risks and disparate health outcomes, as you said, Joya, on the deficiencies, cognitive or cultural, of those who are falling ill. And that tendency to psychologize a social and material problem is very profound, not only in medicine and public health, but even in social science. So a social medicine view is not only the part that Dean Bekele brought up, which is thinking about the community you live in, how you sustain, feed, nourish, your students, how you interact with those who would not normally have a chance to attend college, how could they be integrated into universities. In addition to those, we're talking about really critical analysis. And so one of the things, just going back to Tom and MDR-TB, if you think about this from a social medicine perspective, not just in terms of accompaniment and design of programs, as has been detailed by you, Agnes, and Ababy, but you think of it as a problem. One of the things that we saw with drug-resistant tuberculosis, as with AIDS, is clinical nihilism. So what's clinical nihilism? Clinical nihilism is when you say, well, it's really too difficult to treat this disease in this setting, right? So AIDS across the continent of Africa, MDR-TB wherever it was a hassle, meaning again, in settings with very restricted resources, that's clinical nihilism. And you saw it with AIDS. What we're seeing, I think now, and this is one of the benefits of having a social medicine approach, so you can step back and see where clinical nihilism is rearing its head, right? It would be very difficult to say, for example, in the afflicted city of New York at the height of the epidemic, well, this is our standard of care for people from Manhattan. We have a different standard of care for people from the Bronx, right? So clinical nihilism has a hard time playing itself out in settings of affluence. But what about containment nihilism? That is, not that it's too difficult to treat COVID, but it's too difficult to prevent its spread, to do contact tracing, to understand how to slow down transmission when there's already so much of it going on in the community. That is containment nihilism. So these two patterns have predominated clinical nihilism, especially in 20th century Africa under colonial rule, right? And containment nihilism, which often was tantamount, it was a de facto nihilistic approach, but it was intended to be to corral up patients. So stigma is related to a host of different phenomena, and the best and safest way we can have to address stigma with COVID and with MDR-TB and with HIV is to do our jobs and provide good clinical care. Because unless we believe there is a biological reason for such grotesque health disparities in both risk and outcome with COVID and MDR-TB, we're going to have to look harder at the social roots of these disparities. Anyway, Tom, forgive me if that was a bit long. I just wanted to make it clear that I regard studies of stigma as important. The real question is, where do they come from? How are they related to other public health paradigms and regimes, and how can we get disparities out of the body?
Thank you, Paul. And Agnes, this is a question for you because there's several questions on leadership and governance. And since you among us are the one who is a minister, I would love to hear from you sort of what is the role of leadership in addressing inequities? Like, how is that structured? I was thinking maybe even describing some of the ubudehe categories and how those decisions are made might be useful for people to understand.
You are right, Joya. If, first of all, the leadership in addressing inequities have to make the population concerned participate, because they have solutions that we don't think about where we are as position. And for example, in Rwanda, how to really recognize somebody in need. And of course, it's not 100% always efficient, but it helps to advance the agenda, is to ask the people in the village, who do you know doesn't eat once a day? Mm-hmm. They will tell you. And focus your program on that. Like now for COVID, what we did, we asked each village to identify those who will not have food if they have to stay home during the lockdown. And we put the leadership is to organize that, but also to make the head of the village that is elected by the village in charge of nobody starving in his village. Mm-hmm. Putting the budget, destigmatizing it, and make sure that collectively, here where I'm living, we are helping 2 families without stigma. We do that through the head of the village. We give the money to the head of the village and we just say, it is his job, just take it. So, and we create a system like that called ubudehe, based on a traditional way to give social support to each other. When a house was pulling down, everybody was coming to help you to build it back. So we took this name that talked to the cultural memory of the nation. And so the role of the leadership is to identify with the people all the inequities that pull them down and avoid them to go forward, and especially in a crisis like that.
Yeah, thank you. Thank you.
And what is important is that when people are afraid, if you bring divisions based on the fact that people are afraid, you will always find people to listen to you. And a true leader brings the people together in crisis more than ever.
Yeah. I'm going to take this moment to ask Dr. Sheila Davis a question. You were involved in HIV in the United States early on and clearly saw the impacts of racism, as Paul was saying. And there's a couple questions about the US health system, which you were spanning for many years. What do you think attributes, how can we attribute this incredibly high spread of COVID in the United States? There were a couple of questions about that, and maybe Sheila, I can ask you to take a shot at that.
Sure. I think these disparities existed before COVID, obviously, in regular routine care and oncology and in treatment in general. I think we're just seeing it daily or every hour in the news because of COVID-19. So I think to me it's more of representative of the lack of a quality healthcare system for the most vulnerable communities and populations, and that's where COVID has kind of found its entry into that and has certainly caused havoc. So we can certainly address COVID in the world and certainly in the US, and we should be doing that. But we should be doing that by building a health system that is not just focused on high-tech hospital care, but one that's also focused on a strong public health system. We should have community health workers in the US that are widespread, working in urban areas and connecting people to care throughout their, to provide a comprehensive model. And I think that we're really seeing in a much more tangible way that our health system in the US now is very focused on hospitals that are high tech, the most expensive places to get care, not the most accessible for people who don't want to venture from their own communities. So the best way we're going to be able to address that is really pushing care into the community and working with the community to figure out the best ways to do that. During HIV, we had parish nurses, we had nurses in mosques, we had nurses who worked in beauty parlors. We pushed care into the community of the most vulnerable. And I think that was effective, one, in reducing stigma, because education and access to care is certainly one way of doing that, but also I think would also benefit just overall care in general and reduce the really shocking disparity by zip code or by a few miles on a subway train that exists in the US. So I don't think that COVID has done anything but shown us that this is apparent every day. And so the only way we're really going to address this, I think, is to impact and change the entire public health system.
Thank you, Sheila. I think maybe as our current CEO for Partners in Health, you can talk about how we're trying to, both respond to COVID and provide services and deal with this pandemic of racism that we face, the epicenter, I think, being the United States, but that is certainly part of this globally.
Yes, definitely. And I think, as we look internally at our organization and just how do we function as a global health organization that was founded by, in Haiti and in the US, but is challenging a time as we look at how do we really decentralize and have the most decision-making to be in those who have the closest proximity to those that we're caring for. So I think it's important that every organization looks at itself and says, what is the ways that we should be making decisions? And how do we actualize that in real, tangible ways? I think we've made some strides, within PIH in the past year, but I think we really have a huge way to go as we look at how racism has really impacted how much of our structures in the US have been set up and how global health in general has been really built on very much of a colonialistic view and how funding is dispensed on our donor community. So I hope that we don't let this time go by without doing some really significant introspection about how are we really going to use this opportunity and the tragedy of George Floyd and murder of so many people to address these core issues that are looking at the most vulnerable in our societies. And it's not going to be easy. It's certainly going to be a process that is going to take us a while, but we don't have a choice. We don't have an option to do that. And I think we'll be a stronger organization when we're able to do that and when we face these things and make changes to address and become a stronger advocate and deliverer of care that's based on an equity model.
Mm-hmm. Thank you. And Dr. Bekele, Dean Bekele, I was wondering if we can ask you a bit of a question about that, because I think the topic of racism has, come out so strongly in the United States, but you have been, and we have been trying at UGHE to teach about that from the African context around colonialism and the discourse around colonialism. Wondering if you can share some of the fundamental things that you're teaching at UGHE around colonialism and how it impacts health as well as how we see health.
Thanks, Joya. To be academic about it, all our students take modules around colonialism, African history, social justice, gender equity, social justice. This is just the academic description of what we are doing. But when we go deep into it, And when we look at the medical school curricula, for example, the responsibility of a general practitioner in Africa and in the other parts of the world is completely different. General practitioners in Africa are expected to perform lots and lots of surgery, including cesarean sections, laparotomies, appendectomies, lots of trauma. I could also cite numbers. More than 50% of cesarean sections in some African countries are performed by general practitioners. This is not the case in the developed world. If you look at emergencies like in internal medicine, for example, complicated diabetes, hypertension, all sorts of infections, MDR, TB, pneumonia, even COVID care is now the responsibility of general practitioners. Pediatrics, OBGYN, complicated deliveries are all the GP's responsibility. So UGHG, at its inception, decided to design its own context-oriented curriculum that addresses disease conditions that are common here in Africa. 90% of what GPs do are around emergency and surgical care. So our students, by the time they graduate, hopefully will be able to do cesarean sections, laparotomies, and closed fracture management and wound care. They will especially be trained around emergencies. This also holds true in our new programs we are thinking of starting, like nursing and midwifery. The second is the way we teach. Gone are the days where doctors and nurses sit in a room, patients come to them, after 5-10 minutes, prescriptions are written. Those days are gone. Our doctors need to be able to understand the determinants of health around them. It's easy to write an anti-TB prescription for 6 months, but are we sure patients will take them? Are we sure patients have the necessary diet, social support to be on anti-TB for 8 months? So we made sure our curricula is a little bit different and context or oriented to us to fit our need. So that's how we try to address these problems a little bit.
Thank you, Dr. Bebe. I want to take my moderator's prerogative to just answer a couple of questions, and then I'd like to turn back to Paul for some kind of clarification. So a couple of people asked, what is Paul saying about nihilism? And so being that I, for more than 20 years, have learned to speak Paul, I will break it down to those of us who are not anthropologists and maybe aren't as sophisticated thinkers as I am not. So, the idea of nihilism or nihilism is that there isn't really a moral basis. So we proceed in a very transactional way without a moral underpinning. That's the foundation of the idea of nihilism. That life itself doesn't really have meaning. It's just a kind of a transaction. And so when we think at Partners in Health about nihilism, it's been for us, I've long called it public health nihilism, that the public health practitioners—
That's a species too.
Yeah, the public health practitioners say, well, you know what, it's too expensive to treat drug-resistant TB. And indeed, the WHO was saying that. Therefore, you can't do it because essentially there's no moral obligation, that your narrow envelope of money that you have just won't cover it, so you can't do it. And so that view we consider nihilistic and immoral, right? It is, when we use the term nihilism, we mean it doesn't have morality attached to it. And so part of the work that we've been so privileged to do in Rwanda, part of the work that Dina Bebe was doing in Ethiopia before we were able to recruit him over to UJT, was really about pushing back on that and saying, every life has value, and in the 21st century, the modern medical surgical care has a moral value. And so the reason I'm jumping in here, and I'll feed it back to Paul, is that a lot of this work is not easily funded, right? In impoverished countries, it's not chosen to be funded. In the United States, in rich countries. So when the questions come up is, how can we do this in a poor country? We believe we're in this together. And part of having the teaching, part of developing these intellectual arguments is not just for a pie in the sky academic idea, but for the practical use of these arguments to make international and national policy. So we want to help you and build a community of practice that can make these arguments that the moral basis of care is there for everyone, regardless of the country they live in, regardless of the color of their skin. And in fact, we would say there's even more moral obligation among communities that have been historically impoverished. We owe those communities more because their suffering has been greater. So we're not saying everyone can do staff, space, and systems and social support. We're saying everyone needs it. Let's work together to make this part of our ethos as a community, and then not accept nihilism of any sort, whether it's, well, treatment is too expensive or prevention is too hard, that our foundation ought to be a moral one. And when we talk about social justice, the idea of justice is fundamentally a retrospective concept, right? There's no justice without saying a wrong was done, right? I don't say, well, my justice is having lunch. My injustice is giving lunch to a person who have had lunch withheld from them, right? So when we talk about social justice, we have to do this analysis of who has been wronged, why, and what are the terms of a moral improvement that will take. So I hope that can help people understand a little bit what Paul was saying about, saying, well, treatment is too expensive, or it's too hard, or prevention, it's too late. These are all nihilistic or amoral arguments that don't value the life of a human. So Paul, want to respond to my pedestrianizing your, your language?
I would say that you were up a notch from where I was, because you were looking at the philosophical and moral bases of nihilism and nihilistic notions. I was going somewhere much closer. For example, the claim that it's too expensive to do something. Well, you can make that claim, and you have to understand cost and price. But here, these nihilistic concepts, like it's not possible to treat AIDS in Africa, had the added disadvantage of being entirely false. Yeah. So, they were also errors, right? It is not impossible. It was not impossible. Same with drug-resistant TB. And there are lots of side blows to nihilism, like, and also, the mycobacterium has mutated and is less virulent and less readily transmitted. Those were also, byblows of nihilism. But, let me just ask something to the audience, and I can see some of these comments and questions coming in. There's a reason I believe that Dr. Abebe backed his answers to the question of colonialism so rapidly into programs designed to address disease and to train people to do it. It's not because he's a surgeon, right? It's because, one of the places that nihilism comes from, both clinical nihilism, can't treat it, and containment nihilism, can't control it. Both of them are deeply rooted in colonial medicine, which is a very recent event. I mean, this is a 20th century. And in Africa, it's largely a 20th century process. I was certainly alive already when, as colonialism was being dismantled or partially dismantled. So that's the reason is, I mean, how many medical schools were founded in Sierra Leone in 200 years that the British claimed it? 0. How many nursing schools? 0. So in 1962 or 63 or whenever, you can't talk about surgical care, injury, all the things that general practitioners are doing. You can't talk about them because people are going to say, we can't do this. We can't respond to these injuries and illnesses. And it's true, they couldn't. They didn't have the staff, stuff, space, and systems. So one of the questions I was asked, or that came through to me about the 5 S's, was regard to COVID. And imagine, again, clinical and containment nihilism without staff, stuff, space, and systems and support. You just can't do it, right? So this whole discussion of what is possible with limited resources is one that's really hard to have in the 21st century after so many resources have been looted from that continent, where it is now claimed it's not possible to either treat or control an illness. So those are the roots of nihilism, or clinical and containment nihilism, as far as they are concerned with epidemic disease, particularly on that continent. And I think we should all be literate in it. And I draw my literacy from social medicine.
That's great.
Is that an okay roundup?
Yes, I think that's great. We still have some time, and there are so many great questions. You know, I know that Manzi and Phaedra, who have, you know, will kind of wrap us up in a few minutes. But one of the things I thought would be great to go back to Dr. Agnes about is really, again, about how do you look at racism, colonialism, and the politicization of health. I mean, one thing we all say is health is political. And as you were a political appointee, how does this sit in the brain of a minister, or now the vice chancellor of a university, which is private?
First, as a minister, when you are asked to be a minister, you may say yes, you may say no. If you say yes, it's because you embrace the politics that you are going to serve. You are not going to be taken to do your own thing. You are taken to make a global, national political agenda real. So me, I was very proud because the head of this nation is a man for whom equity is a North Star. And and as Vice Chancellor, we have equity in our name. So it's very easy. We need to breathe, to eat, everything we do is equity. And you can see that society where racism exists are society based on inequities. And there are society that are based on the society where a portion of the population decide that the life of a group, the right of this group to life or to justice is not the same as for another group. So this is the basis. And you have that in society that you cannot have leadership that promotes racism and equity at the same time. Because equity, you go to the most vulnerable. And it's not to say that in my country, they are no vulnerable. And it's not to say that nobody is educated to always feel superior to another group. We have to fight it. We have to make sure that the most vulnerable among us, the place where we live, are the one we put in front of any type of decision and any type of outcome we want. That's the only way to fight racism, as a minister or as a vice chancellor.
Yes, thank you. Paul.
You know, I just wanted to, I'm sure that Agnes was triggering us by saying it is impossible to fight racism when, you know, you're reporting to a chief executive who is a racist. And she made that comment after noting that equity is a North Star for not just the president, for a number of people in high-ranking positions, as it was the case when Agnes was minister and after, right? So there you have it. We live I live as an American, I live in a place where I'm pretty sure, I'm confident that the chief executive is a racist, right? But that doesn't mean that Tony Fauci shouldn't be working in the federal government. That doesn't mean that people in HHS, our equivalent of the Ministry of Health, or in other federal bureaucracies, you know, who work by definition for the government, are not needed. I think, you know, when you have a situation like this, and some people, and I'm looking at some of the BLM comments and questions, some people would argue that we've always had a CEO like this, right? That, you know, if out of the first
Let's say a president, so people don't conflate that with Sheila.
Yeah. And
I mean, you know, Roosevelt made some very grave errors, as anybody of Japanese descent or from Japan will tell you. But that doesn't mean he was like, you know, like Trump. Is that clear enough for you, Joya?
Yes.
And so I would just, you know, say that as we struggle here as clinicians, academics, community activists, you know, and by clinicians, I obviously include nurses, doctors, community health workers, social workers, psychologists, people who are on the front lines. You know, what I think we should do, and again, this has been said by several people, is keep asking how might we expand the fight against racism at this current time when we do have a government riddled with, in the United States, riddled with incompetence and ill will, but also riddled with really good people who are trying their best to avoid both clinical nihilism and containment nihilism. And that was the case, you know, in Rwanda all the years I've been there, but I was there after the genocide. But in Haiti, where I have lived through, as a number of people listening, in Haiti, where I've lived through many coups and more ministers of health than I can ever think of, and I doubt any of them served 5 years. You know, there are always ways to work with public health authorities with real conviction, even in crappy governments, right? What about at the village level? What about the town level? What about the district level? What about the county level, the state level? And I think we in gearing ourselves up for a very prolonged battle against COVID and racism, you know, we should be looking for allies where we can find them. And that's, you know, not my job to say. I just want to add it.
And I agree, Paul. Joya, I want to make a difference.
Yes.
Tony will never sign an inequitable order.
Yeah.
Got it. So,
yeah.
And when you are a minister here, you lead the politics of your sector, the laws, etc., etc. And you cannot do that if it's based on inequity and stay there. I just want to but it's not for that where you are, you cannot do your best for that. And thanks to Tony and all the others. Yeah. What I want to say, they will never go to Congress and say, let's go for law if it's inequitable.
Yep. Great. Okay, well, we had a really fruitful discussion with plenty of time. There are so many great questions from Kenya, Zimbabwe, Palestine, the US. I mean, we're just so delighted. We are going to have an office hour after this, so there is time to address some of your other questions, and I want to turn it back over to my friend and colleague, Dr. Anatole Manzi.
Thanks so much, Joya, and everyone. I think this was really amazing. I learned a lot, and I hope it was the case to everyone here. So this is really good. So Kelsey, if you can have the slide over. So thanks. So the next session is coming up. So Thursday, July 9th, so same time. You will have a new link to call in. So remember to check out all the materials related to that. We have pre-readings, so please have a time to read those readings prior to that session. So there's a survey. You should have a survey now. The survey that you have to complete. So it's a requirement for those who want to earn a certificate. Amy mentioned this prior to this session. We look forward to having you attend the 4 sessions, but also complete the surveys that we are sending every single day at the end of the session. So I guess at the end of the session, you should wonder, do I have to come back? Yes, absolutely. I saw so many who are saying, this is really what we needed. So please come back, join the next session. And before you go, we have office hours because we learned that there are so many who want to ask questions to our panelists. It may be a personal question. It may be just connecting personally. Please stay. We have 30 minutes to 1 hour. So if you want to stay, please do so. Again, back to my question, should I come back? Why? So I would like to invite my colleague, Dr. Phaedra Henley, to tell us a little bit about the objectives for the next session. I guess that would be helping to help understand why you should come back to the next session, which is now getting to more details of this topic. Phaedra.
Thanks so much, Manzi, and thank you to all of our panelists and all of the participants. I've been reading all the questions and there's some really excellent ones, so we'll be sure to find a way for you to be able to get the answers you want. So next session, session 2, is this Thursday, and the case is about contact tracing and equity, the role of wraparound support in Massachusetts. So Massachusetts is a state in the United States, and along with Partners in Health, the Department of Public Health of Massachusetts launched a community tracing collaborative to support the implementation of contact tracing by local boards of health. This collaborative focuses on reaching out to the contacts of confirmed positive COVID-19 patients to ensure that they have the support they need to self-isolate and to help protect others who have been potentially exposed to the virus. Key to the effort of the collaborative has been mounting a new cadre of care resource coordinators, helping to provide wraparound services to the most vulnerable. This second session, session 2, brings senior technical advisors of the Massachusetts response to share best practices and preliminary lessons. Beyond the epidemiological surveillance, these faculty and expert panelists will highlight the human-centered approaches to tackle COVID-19 and pandemics. So we're really looking forward to seeing you next Thursday, this Thursday.
Thank you, Phaedra. And for those who want to stay for our office hours, we will take a short break for 5 minutes. Then we'll come back with our faculty members. So for everyone else, thank you so much for joining. We'll see you soon.
Yes, I just wanted to add, we will be placing the recording of this on the website. I know a lot of people have asked that. We also will place the slides on the website as well. So look for that later and you'll get an email from me with a reminder that everything's up on the website. And we'll put some more links in the chat now for you.
Thanks, Emmy. 5 minutes. All right, so thank you so much everyone for staying. So we moved from thousands to 800 participants who stayed for questions. This is great. So we still have our panelists and our professors today. So Joya will serve as a discussant, and we have my colleague B, who will also help to collect all your questions. We also know that we have a section to answer the questions, so we will be able to type some answers to you. So we understand that we will not necessarily have it, and we may not be able to get to your specific question, but we do our best to reach out to you with a specific answer. So if we can. Otherwise, we still have 3 sessions remaining. We'll be able to address most of the questions. So over to you, Joya, if you got some questions. And B will be there helping. B, if you could go ahead, that would be great.
Yep, I see a question, first question about actually the projected need for medical anthropologists going forward.
Is that for me?
Yes.
You know, over the years, I was lucky enough to study both anthropology and medicine at the same time, but there are very few ways to do that in this country or anywhere else. It's just poorly financed, and maybe there are other priorities. But then you see the value of a really socialized view of an epidemic or a clinical problem or a social problem, right? And we're living in a time where people understand that. So whether or not there are adequate financing mechanisms for that specific field, I don't know. What I do know is that all of us can do more to read social history, and if we like ethnography, social anthropology, all of the master's students, many of whom are on the call today or working with us, have done so. So I think there's a great need for medical anthropologists, but medical anthropologists who get involved in addressing deficiencies in staff, space systems, and support. That's not all anthropologists, you know. Some are only indirectly involved in this work. So I guess what I'm saying is I'm glad I had that training. I hope that I can move forward the agenda along with my colleagues at UGHE to make sure it's available there as it is in a few places on that continent. But most of all to say, you know, all of us can get better at understanding. You know, we had a great question from one of the people, I hope it's still on, from Newark, and it was phrased as a BLM question. It said, look at what happened with the Great Migration in the early 20th century of African Americans from the South to places like New Jersey, and how the health responses, how the health needs there were met with this rapidly burgeoning public population. And the answer is, I don't know that, but I could read about it. And I bet someone who's saying that does know more about it. And that's what gives me such optimism about social medicine, is regardless of what disciplines we use to expand our understanding of epidemics like this, or epidemics of racism for that matter, we'll have a need for people who can look around carefully and look back in time.
Thank you. Thank you so much. There's a question about actually what is happening with the pandemic right now, and how, therefore, should we be living and trying to really step up our work containing it. And so I turn to Joya. Joya, I think you're on mute if you're responding there.
Yeah, Dr. Yes can also jump in. I think that will be a good question for you.
Sorry, I was finishing something. So say the question again.
Yes, we live in a multitasking world. The question is really, what is happening with COVID right now? And what does that mean in terms of where we should be placing our priorities?
but it depends where you are. You know, there is never in the world where we live one solution fit all. Uh, I can talk what we need here. We need to be prepared and take this opportunity to strengthen the health sector in case we have a wave with more people infected that need more um, clinical care linked to health facilities based with respirator, oxygen, etc. We need to reinforce more the control, the testing at the border to avoid the spread inside the country. We need to have more international collaboration and put our voice on giving responsibility to leaders of what they do, they are responsible for, that any death that is due to leadership negligence should be taken in account. So I'm sure Paul will say the priorities in United States are not exactly the same, even if the virus is the same, even if the way people suffer and die are the same, the priorities are not.
You know, B, one of the questions, just while we're waiting for Joya or Sheila or anyone else to respond, one of the questions was really underlined. This is one of the few, one that popped up during the course of the hour. And I have a hard time, you know, digesting all of this incoming, whereas my children do not. So in any case, the question was, okay, you're saying that, you know, a number of affluent countries in Europe or the United States have, you know, have had worse epidemics or are having worse epidemics than in Africa. And you also said that a lack of, you know, staff-based systems and support would mean catastrophic epidemics in precisely those countries. So what gives? And that's the same as asking, where's the epidemic going globally? In the United States, you know, there are going to be contested readings of what has happened, much less what will happen. And, you know, I think that what we've seen is obviously, as had been mentioned, failures of leadership, failures of understanding the depths and extent of community-based transmission and when it started and when it, you know, what's moving it forward. Clearly, it is moving into vulnerable populations. Again, everybody who does works in the tradition of social medicine, and of course I'm including surgeons, and I'll go back to that in a second. We need to know where it's going, and it's settling in to all of our social faults and fissures, right? Okay, people now understand that. So what caused the current crisis? Because, you know, is this part of the first wave? Is this a second wave? I think it's part of the first wave in the United States, and we just relaxed a number of stay-at-home orders and other social distancing messages, or failed to enforce them at a very crucial time. A lot of us worried that the major demonstrations in which many of us participated would lead to a spike in cases. Michael Osterholm from Minnesota says that the research does not appear to suggest that, but rather that more of the spikes, which are truly colossal, and we have 50,000 cases a day, a number of times over this past week. So we're in a lot of trouble. Wherever the epidemic is going in the United States, it's not going away in short order. And that's one reason that we're looking to Rwanda, because Rwanda has had so few cases and even fewer deaths, and was prepared in a way the United States was not, in spite of the lack of staff, space, and systems. Now back to that initial question, and I'll stop. I fear that we're going to have a major growth in the pandemic in places that are considered developing countries, or wherever the term may be. The terms change over time as well. But there's little reason to believe that in northern Nigeria, certainly in across Latin America, parts of India, and maybe lots more of it, that we're going to be seeing a number of new cases before we see any kind of retreat on a global stage. The reason I mentioned surgeons is because, as Agnes said, it matters where you are. And right now we are stuck with the nation state being the default polity that we discuss. And as John Mira, a surgeon, pointed out in a recent talk about COVID, ever since the Treaty of Westphalia, that's been the default default measure. How's it working on a national level? So I think we're stuck with that, even though the epidemics, the pandemic itself is, of course, transnational, transregional, and global.
Thank you. Related to the type of care and accessing care, there was one question about how that's working in Haiti. And is there, even in the best hospitals, is there good access to care, and how can that be dealt with?
Well, even though it's out of turn, I'm the only one here who's been to Haiti recently. And I would just like to say, at the outset, what a great debt we have to Amis La Santé, to our colleagues in Haiti, who have been named at Mirbalais, the National Referral Center, who have, for COVID, who have conducted research, who've been caring for literally hundreds of patients, and many of them critically ill. Thank God we have the staff, space, and systems and support in Amis La Santé, but that is not the case in most of the country. That's one reason so many people are coming from across the country to Central Haiti, which is hard enough when it doesn't concern a communicable pathogen, right? So there have been all kinds of social problems. There have been supply chain problems. But I have to say, and maybe Sheila, you could just say a word. I have to say I've been distressed by the way the epidemic is moving forward in Haiti, but deeply moved by the experience of our colleagues there. Sheila, I don't know if...
Yeah, no, thanks, Paul. I think, I think the Amis La Santé team, as always, is the ones who guide us in a lot of the clinical care and isolation centers. Some of the back wards of the hospital have been turned into COVID-19 units. There's also isolation centers outside. There's our partners, our good partners, Build Health International, have just completing some outdoor isolation beds and centers. And, we know oxygen is a huge need in this. And luckily, Mirbalais Hospital has had an oxygen concentrator, and we've built that up and supported that through the past few years. But, I think this is even more, reason why University Hospital at Mirbalais has been the center where people are going is because it has 6 operating rooms. It has an emergency room that functions very well. It has the ability, it has the oxygen concentrator. And if those things hadn't been built up and invested in over the past few years, it would be the same circumstances. So we luckily have phenomenal clinicians there who have been trained, who know what to do and are really, I think, leading the effort there. But it's a challenge, I think, as we look at hurricane season coming, worry about access to, PPE, just as we do in every country. So I think we're learning a lot, but also very worried about just a huge number of cases that can really decimate even healthy health systems.
And can I add to what Sheila is saying, that, I think back to this topic of nihilism, like do this and not that, because there's no sort of moral calculus for what we do. When we went ahead and built this tertiary care hospital as a response to the terrible tragedy of the Haitian earthquake, which is now 10 years ago, we didn't have a lot of the international experts praising this decision. In fact, they were saying, why would Haiti need ventilators? Why does Haiti need operating rooms? There's people dying of diarrhea. So that, again, would be this kind of nihilism of the public health approach alone, just in general nihilism, that you shouldn't really be doing anything extraordinary. But then once you invest, and we've seen this so much in Rwanda as well, once you invest in systems, these systems serve you quite well for many other issues, right? For other disasters, whether it's hurricane floods, for other epidemics, whether it's Ebola and or COVID. And so I think when it disturbs me in the United States that people say, well, Trump disbanded the pandemic task force, as if that singular thing was what put us at risk for COVID. That is not what put us at risk for COVID. What put us at risk for COVID is decades of gutting primary care, gutting public health, privatizing a system, focusing on monetary insurance instead of the provision of care. All of those political choices that were made over 40, 50, or even the 250 years that we've been around as a country are what put us here, not a task force. And so building these systems, and there are many questions, how do we do this? We are interdependent, and we will fight with you at UGHE. UGHE is for you, right? Partners in Health is for you. We will fight with you for global cooperation in this. And we need to continue to keep our eye on global cooperation, as we've seen with the Global Fund, right? The Global Fund was created out of global cooperation and solidarity and money for the global AIDS response. We need to keep pushing on the idea that we're totally interdependent.
Thank you, Joya. There are questions really related to sort of the overall strategies of social distancing and how those are affecting economic activity from both a rich country and a poor country perspective, and what can be done to move forward while enabling people to earn a living.
I mean, one thing I will just say about the upcoming lectures, and I'm happy for anyone to answer that question directly, is, but you will see that Manzi and Phaedra have really created a very robust set of cases. B, of course, was essential to that, Amy, the team. So we are going to have a deep dive on that specific question for the United States, right? We are going to be looking at racism and COVID in the United States through the lens of the Navajo Nation. We are going to be looking at Rwanda's outstanding response. So you'll be able to see with these cases some of the details of the questions that are coming up now. So we can also answer them, but we are going to have some deep dives into these specific, like how do you do this? Because I think that's really important.
Yes, and I hope people are able to continue to come back to those sessions. There are also a number of questions about whether or not how to build the momentum around investment in public health, and particularly for countries that may be under-resourced or face other challenges. So Dr. Agnes, maybe you could speak to that.
I think that we try and we miss the point with the Ebola outbreak. We are not allowed now to miss the point again. So we need to build the momentum, because we had COVID is really a tragedy, but if we don't take the opportunity of the global understanding of this suffering, there is no place on earth who was not impacted by that. To change that idea that providing care, you can do that under a tree, yes, but you need to create a health system that is solid and that will take the shock of what we don't know tomorrow will be. And if we don't do that in between crisis, next time it will be worse. So we have this momentum, we have to scream, we have to write, we have to ring the bell everywhere, say that it's not new. We have said that over and over. We have already the Ebola crisis, who show us that Liberia, Sierra Leone were really impacted, not at the same level as Senegal, Mali, and Nigeria, where the outbreak entered and was controlled because of the health system. If we don't create and reinforce with what we have learned, we are going to miss the point. So the momentum is now. We need to create the network of global health. And all of you who are listening to us, please join us. Your voice is key. We need to create the network of the global health fighters. We need to create the network of the good politicians. We need to create the network of the scientists. We need to create and bring. That's the only way to keep the fire alive.
Yeah.
You know, if I could add something, Joya,
Yeah.
just in the spirit of that great question, you know, and I'm sorry I didn't respond to it, the one about how can it be so that, you know, if places with the fewest resources are the ones that are going to be hit hardest, when that doesn't seem to be the case. In the spirit of that question, you know, I just think that we also need to have our bullshit detectors on. And there are, you know, if Rwanda is elevated in this way, it's not because we're Rwandan, although we are. It is because we're looking at, and not just because we're the architects of this, which I'm not, but you can watch carefully and have your bullshit monitors on. To go from where Rwanda was after the genocide against the Tutsi to now required enormous investments of staff, space, systems, and support. And it's not, you know, it's not juju. Rwanda has the highest fraction of public resources from its public treasury put into healthcare delivery of any nation on the continent. So again, you know, it's not some mystery of Rwandan exceptionalism. Aren't these people great? Yeah, they are great, right? But they're not magical. When you heard the claim made after the Ebola's outbreak in Eastern Congo, you actually had experts, some of them people I know and admire, saying, well, you know, the Congo has a lot of experience with Ebola. They'll know how to handle this. That's an absurd claim. That's a bullshit claim. You know, just because you're afflicted by, you know, a horrible epidemic doesn't transfer magically some kind of knowledge of how to organize a response. It's just an absurd bullshit claim.
Particularly when you don't have the economic need.
You don't have, you know, and those are the kind of things that we should watch out for. I would just add that, okay, well, Rwanda's putting 20% of its public budget into you know, healthcare delivery and preventive health and focusing on social determinants, et cetera. Well, so is the United States at putting 16%. That's not the same money. That's 16% of the US GDP, but a lot of it is out-of-pocket expenditure. A lot of it is, you know, it's not a national, and it's a private system. So it's completely different, incomparable. And I just think that when we ask questions like the ones that were asked and was directed to Agnes, we need to have our bullshit detectors on. And
also the other bullshit way to think is believe that the problem is money. No, the problem is your heart, is your brain, is to put your ideas to serve the most vulnerable of your setting, and do policies plan to target those, because when they are served, all the people like you and me that are the privileged one will be served as well.
Good. Yeah. I just put in the link. There was a question earlier on about, you know, how do you design these systems? And, you know, we did several of us from across Partners in Health did a workshop at the International AIDS Conference yesterday on how we do morbidity mapping, which is actually looking at the burden of conditions, including diseases, including the need for social support, and then trying to align our work with that. Why is that important? Because it is a way to combat the idea that there's not enough money. Rather, we say, okay, but there's a lot of disease. There's a lot of conditions that need to be addressed. And then how do you know what those are and create plans, as Dr. Agnes is saying, put in the staff, the supply chain. And these were lessons that we learned in Rwanda and Haiti and elsewhere around HIV. We never sat back and said, let's do the best we can with the resources we have for HIV, because we said, no, our goal from the beginning was to get everybody. get everybody in the tent. And it's the same with something like infant vaccination. Our goal is to get everyone. We don't say, oh, let's do the best we can. And if we get 30% of people vaccinated, that's good. But we haven't done that with health writ large, nor have we done it with social problems. And what we're seeing in Massachusetts, for example, is 11 to 15% of people, and you'll hear more about this in the next session, need some level of social support. It's probably higher than that, but that's the ones we've been able to help right now. That is exactly the number of people who live below the federal poverty line.
Hey,
So
I also want to, have Sheila to comment on that. I think that's really a great point. And I know, Sheila, you may have a meeting coming up, but it would be great if you could also talk about how to shift priorities as an organization, especially, how do you shift priorities to respond to pandemic? And what is the role of nonprofits, especially, with the public institutions? So I'm sure you have that meeting coming up, but it would be good if you could talk a little bit about that and as you transition.
Yeah, no, thanks. And I think just to add on to that past conversation, I think we really need to work on the donor community. When during Ebola, there was like $4.3 billion of the 2014-15 epidemic in West Africa that was pledged. I mean, granted, certainly not all of it goes there, but that was pledged. And when in 2012, there happened to be an assessment of what would it take to stabilize Sierra Leone, Liberia, and Guinea's health system, and it was like 1.3 billion. So that was never pledged or given because that's considered too much money. And then during emergency responses, there's always such a different approach to funding, and it really has, I think, caused this bizarre dynamic to be set up where emergencies will gain attention and there'll be funding, which is often very siloed, does not build on leaving a health system behind, but very specifics of what you can spend money on, what you can't. We couldn't buy a labor bed during Ebola, which was ridiculous. There were so many different things we had to fight. So I think we also, just as we are mobilizing, I think we have to hold our donor communities and our donors to a very different type of feedback and analysis, and pushing back to say it's short-sighted to just fund emergencies. And we certainly, that precedent, I think, has to change. And there needs to be an evaluation of whether funding is actually used and in the benefit to the long term as well, because this continues to be this cycle that we've seen obviously for decades. And West Africa's health system, had that 1.3 billion been invested in 2012, I think many fewer people will have died because there will have been some semblance of a health system that was there it left behind during that investment. So to building on your question, Manzi, I think that's where NGOs have to partner with public sectors. So I think we have to work with existing governments to build these and strengthen these health systems, during emergencies like we did during Ebola, but also beyond that, and staying beyond and working on long-term solutions based on where we're working and their priorities. So we can certainly play a huge role, and by us really insisting that we're not setting up parallel systems, but that we're supporting the governments like Rwanda, Haiti, and others. And that's the only way we're going to change this dynamic, I think, is the critical piece of the roles NGOs play, and also in terms of us really pushing our donor communities about these funding restraints that I think have hurt so much more long-term, rather than looking at and what we could have left behind through all these, very generous in some ways contributions, but also in some senses short-sighted. So unfortunately, I do have to leave, but certainly look forward to the next session. I think this has been great, and look forward to continuing to learn from everyone. So thanks, everyone.
Thanks, Sheila.
Thank you.
Thank you. All right, Joya, B, do you have any more questions? I think we budgeted for 30 minutes to 1 hour, so I think realistically, if people feel exhausted, this is just office hours. We can eventually say 10 to 15 minutes, we can wrap up.
That sounds good.
We're feeling the opposite of exhausted with these questions. If I can say, because I don't know if Agnes will say it, you know how shy she is.
No, she's not.
When you ask, okay, which again, I'm asking the participants in this workshop to understand what containment nihilism looks like and what clinical nihilism looks like. It's important that we understand what has happened in Rwanda, which again is going to be highly contested, right? Even the response to the COVID will be contested from within and without Rwanda, and particularly without, by the way. But what does that kind of leadership get you, right? That's one of the questions that I think it's difficult for the Rwandans to ask. How great is our leadership? They're not going to ask that. But one of the claims that we would make is that it is not an accident that the steepest declines in mortality ever documented anywhere at any time on this planet have been in Rwanda over the last 15 or 20 years. And that in and of itself should be enough to say, what are we doing wrong that we're not getting those kind of returns in country X, like the United States? And how, because the way the money's budgeted matters, just maybe not as much as what it's budgeted for, but pretty close, right? So, I do think that even though to me these are not the most interesting aspects of an epidemic, how do public budgets, shape responses? It's something we have to know. I'm turning it over to you, Agnes.
Manzi, to complete what Paul is saying, it is 100% linked. Because if in Rwanda we have managed to achieve so much with not more money than elsewhere, is because we have focused our policies on the vulnerables. Sorry. There are too many to add an S on that.
Good correction.
I'm learning from you, my brother. So what is important to know is that what Rwanda is doing now with COVID is exactly the same that Rwanda did in 2000, 2001 up to today. Focused on the vulnerable. Decrete and lockdown is for all and protect everybody. But how are we going to make the vulnerable cope with it? They've got money. And not like in some country, the more you are rich, the more money you get. No. The more you are rich, the less money you get. Because those who need this money is the people who cannot get money in another way, etc. So the outcome of building this country and the outcome of COVID management are based on the same principle. And you can forget everything. Those who are listening to us forgot everything, even your name, your land, your city, everything. Just go and sleep thinking about the word equity and focus on the most vulnerable. If you do that for anything.
Wait, what about containment nihilism? You don't want them to dream about that?
First equity.
First equity.
Can I answer thank you, Agnes. Can I answer some of the questions about communications and corruption and conspiracy theories? I think there's really two elements. There's equity, as Agnes said, and then there's leadership, right? And there's leadership toward equity, right? But there's also leadership from the ground. There are people asked about mutual aid. They asked about the role of nurses, asked about, community. There's a lot of leadership happening on the ground. And we should remember that all health is very political.
We lost you, Joy.
Oh, you lost me?
It's louder.
Oh, okay. All health is really political. And that doesn't mean you have to take on, necessarily the president, but you can. but it does mean that the choices, right? Politics is about how a community responds to the choice, right? And so the choices that we make as leaders, the choices that we make as health providers, the choices we make about who to work with and who to empower are all going to give us more equity. You know, we have, historically at Partners in Health, worked with not only community health workers, but community groups, organized people within communities. And to me, I'm not at all surprised that the Black Lives Matter protests haven't led to further outbreaks, because having been part of those protests, they are well led. They are led by members of the community who care about each other, who are wearing masks, who are dispensing hand sanitizer at the protest. Social distancing is going on. So if you are led by care and care for each other, and that you have this ethos of saying, who is the best person to lead in this situation? Often it's going to be the Minister of Health, but sometimes it's going to be a local community leader, a woman who really understands what the children are going through who are out of school. And so I think what we have all learned is that leadership in health, because health is political, it is really about not only addressing the vulnerable, but listening to the affected and being guided by the people who are the sickest, the poorest, and have really great ideas about how to help. And I just remember being in Sierra Leone during Ebola and going with one of our community members, and this person explaining to me, okay, there was a man sick in this house and we had no ETU. This was before there was widespread treatment. So what we decided as community health workers is we would separate this man in his house, not make him go to a holding center, because we knew the holding centers were just disgusting and not going to provide the family any solace, deliver meals to the family. And that man unfortunately died, but not one member of that family of 12 was infected. And so given what they had at that moment, there was tremendous leadership by community, by the family themselves, and trying to figure out a solution. So I just feel that, proximity to the suffering and an open ear to listen is also going to always be a North Star for our responses and for us. And I know that's always been part of Dr. Agnes's leadership. That's certainly something I've learned from Paul and others. And I just think that that's a critical piece of the response.
Thanks, Joya. Be any more questions coming from the audience?
I think there are questions that can be taken up in future sessions, and this has been a great session, and really thank everybody for their participation.
Yeah, I think so. This is really good. One of the questions I think I had was, now we have you as global response leaders. I think, I have known you for over the past 15 years or more than that. So many people in this course, they really want to become the leaders. We are all here because we want to eventually lead the current and the future pandemic response, preparedness and response. So what is your roadmap? How do you get there? If we could probably have that around each one of you, if you could tell us, really, I hope this is no secret, then we can actually transition, kind of wrap up from there. Maybe we could start with Paul, please.
Well, thank you. I mean, if I were sarcastic, I would say, well, the roadmap is make sure you're born white in the right zip code. But I'm not sarcastic, and you're here,
And a man.
And a man. Make sure you're a man, right? Boy, that makes me look just so awesome.
High five. No, but you weren't born in the right zip code, were you?
No. But all this to say, I think that the leaders who you're lifting up, Monzi, and have lifted up, are also people who lift you up, right? And so And that's the whole purpose of the University of Global Health Equity is, you know, you could say, does Africa need more universities? Yeah, Africa does need a lot more universities. Major, huge expansion of tertiary education, right? That's not why we built University of Global Health Equity. We built it to cultivate leaders, and particularly women, I might add, in my defense, and yes. You know, I think that looking back, like I said, at Agnes's work in 2003, 2002, 3, 4, at the National AIDS Plan is instructive, because you can see that the support part and the equity part and the accompaniment part were baked in. So now, and this is an old man's response to your question, Monzi. Now I'm just saying, for all those who really care about leadership and what it looks like, if you want the University of Global Health Equity to look like Harvard Medical School in terms of its senior faculty, then you will not take a series of steps that would prevent that or make it easier to remediate, as is happening now at HMS, right? You'd build the university differently, and you cultivate leadership from the beginning. I can just say, as someone began medical school in 1984, I never had a class on leadership. And I bet Agnes didn't either, you know? And so then you have this mystery, well, is leadership born or can it be cultivated? Don't fall for it. Of course it can be cultivated. It is not native to the species, or it is native to the species, all of us, right? And so I would take that question and turn it into a challenge to us to make sure that we spend more and more time developing leaders, and then, as Joya said, listening to what they have to say.
Thank you, Paul. Joya.
Yeah, I was born in the right zip code, and you know, I have a lot of privilege. An American citizen. My father was an immigrant, but came for education, so not a hard scrabble immigrant. But I would say that for me, and I think for many of you, and particularly I would say to the doctors and to the people from the global north, learn to talk less. That was really hard for me. I'm a very talkative New Yorker, and I'm sometimes not great at it. I'm still struggling. But listen, and particularly listen to the affected. I've learned so much from, you know, my biggest lesson that I ever had was from young girls in Uganda who were 11 to 14 years old. That all my degrees, all my years of training was really what I learned from them. And what these young girls told me in the height of the AIDS epidemic in 94, 95, before antiretrovirals, they told me that poverty was their main risk factor for HIV. And I could have said, no, I think it's like they don't really understand, it's about sex. But instead I said, what do you mean by that? And asking that question opened a whole world to me about the complex life of people who are poor, a life I never had. And so I think to the extent that I'm a leader, it's because, at least at Partners in Health, it's because I believe that we are guided by the most vulnerable, the most affected. We want to actually hear what people need and try to design our programs accordingly, and try to hire as many people as we can from infected communities. So today at Partners in Health, 98% of our staff are from the Global South. And of those staff, the large majority, probably 80%, are poor people who we have hired, we pay. And so I just feel like if I were to take a course even today at Harvard on leadership, that would not be what was be taught. I'm just saying, you know, and I did take a class in the business school on leadership, and I was like, that's not going to help me. So we have to think about what is leadership. And I mean, the only term that to me has resonated a little bit, and I think it's so much more complex than this, is the idea of servant leadership. But even then, it's much more complex.
I took notes. Thanks, Joya. Then, Dr. Agnes, please.
First is not to consider yourself as a leader and be humble enough just to want to serve. Let the others believe that you are a leader, but just be there at service. And also, like it has been said by Paul, Joya, yourself, and all along this, listen. And it's so good that in Rwanda we have passed a law. And I was so happy it was the first policy I passed as minister on community health, is that we cannot do policies or plan for the community without them be on the front line. So the participation, service, and the other thing, just build the next generation of leaders. Because if you are just there sitting and believe that you are a leader, you are doing things, you do nothing. It will go down as much the day you close the door. You need to create something that is stronger after you than before you, and that is far more well equipped in people who can do and the right thing than when you came. So do that all over the world and COVID will be managed as much as the next one.
Awesome. Thank you so much for your time. I think this was really super helpful to everyone. So there are so many questions. Honestly, we want to spend the night here and another day. But what we can do is share information. I know Paul wants to say, let's do it. So we're gonna share some more information on the UGHE. So many questions about how do we join UGHE programs? How do we learn more about Partners in Health? So we're gonna collect all this information and we will make sure you get it. So we have another session on Rwanda specifically. I think you will have another opportunity to learn more. So my colleague, my co-director, Fedra, if you have no other comments, I think we can wrap up.
That's great, Manzi. Just want to thank everyone again, all of our panelists, all of the participants. There were so many great questions. We'll be sure to, to follow up on the ones that haven't been answered. And we really look forward to seeing everyone for the next 3 sessions.
Awesome. And special thanks to Amy, who has been behind all these logistics and operations, and B, Melissa, Hannah, Fedra, and Kelsey, and everyone who is really here. We are under the leadership of the people you were listening to, and we will continue to serve you over the next couple of days. Thank you all. Have a great day.
Thanks, everybody. Thanks, everybody.
Thank you.
Everyone.
Bye.
Bye.